are joining by video and have your videos turned off, we're going to have a couple of questions where I'd like to hear your responses to the questions by just holding up your fingers in response to multiple choice questions. So in those questions, just go ahead and unmute, or not unmute, just go ahead and turn your camera on and just do a show of hands in terms of the answer that you want to give for the multiple choice question. So during this didactic, I hope to convey some basic definitions of treatment-resistant depression, help you be able to gather an effective antidepressant treatment history, and then facilitate treatment with some effective antidepressant agents lesser used in the primary care setting. So what is treatment-resistant depression? How do we define treatment-resistant depression? Well, pretty simply put, treatment-resistant depression is depression that has proved to be resistant to any number of treatments. And there's a bunch of definitions in the literature. There are some very facile definitions, such as partial response to one trial, all the way up to non-response of 4 or more trials. Those are very simple, straightforward definitions. And then there are technical definitions as defined by a variety of staging methods that look into all the different parameters of resistance in depression. And we're going to look quickly at the Maudsley staging method because it looks at many factors that are important prognostically when it comes to treatment resistance in depression. This is a copy of the Maudsley staging method. It simply just goes through a list of how long the depression's been going on, how severe the depression was at baseline, how many antidepressants have failed to help the person, whether or not augmentation was used, and then whether or not electroconvulsive therapy was used. And there's a score from I think the minimum score is 3 and the maximum score is 15. This gives you a sense of the degree of resistance. And why are these different factors important? Well, each of these different factors convey some sense of resistance. So for example, chronic depression tends to be more resistant to treatment than acute depression does. So depression lasting longer than 24 months. More severe depression with psychotic features tends to be more resistant than less severe depression. The more medications that somebody has tried and have not been of benefit to that person, the more likely that their depression is to be resistant to the next medicine in line. Similarly, whether or not augmentation was used, and then if electroconvulsive therapy was used and the depression is still present, that tells you that it's highly resistant. So these are just some factors that go into treatment resistance. So when we look at treatment-resistant depression in the literature, how common is treatment-resistant depression? Well, we know that depression has a lifetime prevalence, roughly speaking, of about 20% of people. So this is including major depressive disorder and persistent depressive disorder and bipolar disorder. So about 20% or 1 in 5 people in their lifetime will experience depression. And so if you treat people with major depressive disorder, in the primary care setting, what percentage of them have resistant depression? Well, this is from the STAR-D trial, which looked at several thousand patients in the primary care setting and assessed their remission rates after a sequence of 4 steps of treatment. And these steps were things like, first they started off with citalopram. And then the second step, they either switched to Wellbutrin, or they switched to sertraline, or they switched to venlafaxine, step 3, et cetera, et cetera. So they had just progressively increasing intensities of treatment. And what they found was that after 4 treatment steps, there was a cumulative remission rate of 67%. So 2 out of 3 people got remitted from their depression. What this also says is that treatment resistance after 4 steps is 33%. So basically, when you're working with a patient with depression, there's about a 1 in 3 chance that that person will have some level of treatment resistance. So what do we do when we see somebody with treatment resistance? Well, we really go back to the essential tasks for antidepressant medication management. And we want to revisit several of these steps. We want to revisit screening, diagnosis, and treatment history because we want to make sure that we have the right diagnosis and that we have a full treatment history so that we're not just going back to the same things that have not worked for a patient. We also want to be careful about treatment selection, initiation, and titration. So we want to make sure that we're selecting a treatment that the patient has not had before and that we're initiating it and titrating it with enough support that they can have a minimally adequate dose and they can have a good length of a treatment trial. And then we want to be able to track response and also titrate the medicine, augment it, or switch it. So these are the steps that are really important when you're dealing with somebody with resistant depression. So the first thing is revisiting the diagnosis. So if you have somebody with depression that is treatment resistant, it's important to revisit the diagnosis of depression. You can do a PHQ-9. You can confirm the diagnosis of depression by going through the PHQ-9 symptoms and make sure that you're confident in this diagnosis. And then it's also important to revisit bipolar disorder as a possible diagnosis. And you can do this by administering the mood disorder questionnaire and by confirming whether or not a person has had lifetime manic or hypomanic episodes. And why is this important for revisiting bipolar disorder as a diagnosis? Well, number one, there are high rates of bipolar disorder in treatment-resistant depression samples. So treatment resistance in depression can be a risk factor for bipolar disorder. Number two, it will change your treatment fundamentally. Next, revisiting substance use disorders as a possible contributor to depression, because this will help you shift your treatment so that you're treating the substance use disorder at the same time that you're treating the depression. And then revisiting medical conditions associated with the depression to see if you can optimize treatment of those things. So for example, if somebody has untreated sleep apnea and they've got treatment-resistant depression, could it be that the sleep apnea is contributing to that treatment resistance of depression? And then lastly, exploring diagnoses of anxiety disorders, personality disorders, and PTSD, and encouraging treatment of those things in people with resistant depression. Anxiety disorders, personality disorders, and PTSD are all known factors that can contribute to treatment resistance in depression, oftentimes because when you're treating the depression, you may not be treating the anxiety disorder or the personality disorder or the PTSD, and that may be one of the underlying drivers of the resistance. Next, it's important to revisit the treatment history. And revisiting a treatment history means going through a medication list and asking people after all the different medicines that they've tried. Sometimes having a list of all the different antidepressant medications can be helpful, so people can sort of make check boxes next to them. And then ask them to recall what their diagnosis was and what their dose was and how long they took the medication. And you can either do this by asking the patient to report on it, or by looking back in your electronic medical record, or by requesting records from outside providers that can give you some evidence about what the dose was and how long the person was taking it. And then with each medication the person has tried, ask them what their positive effects were and what their negative effects were. And then you can assess whether or not that treatment trial was adequate. So say, for example, somebody who took sertraline 50 milligrams for 2 weeks and says, sertraline wasn't effective for me. Is that an adequate treatment trial? What do y'all think? Is that adequate? Yeah, Lane's shaking his head, everybody's shaking their heads, yeah. So probably not an adequate treatment trial. It's too brief. The sertraline dose is quite low, right? And so why might somebody have discontinued sertraline after 2 weeks? Well, maybe they had unrealistic expectations about what the medicine will do and how quickly it'll do it. Maybe they had some adverse effect that was intolerable to them. And so this is part of taking this treatment history. This is giving you a roadmap. It's telling you where the person has been, like what places they've visited in order to try to treat their depression, and so that you can visit different places with them as opposed to visiting the same old places. So here's a question, a multiple choice question for you all. A patient with major depression previously received treatment with sertraline 100 milligrams daily for 8 weeks. Is this an adequate treatment trial? 1 is yes, both dose and duration are sufficient. 2, maybe, dose may be sufficient, but duration is sufficient. 3, no, dose, duration is sufficient, but not dose. Or 4, neither dose nor duration are sufficient. What do y'all think? Let's see, we got a 1, got 2, got 2. I know these are kind of like those like GRE questions. You're like, Bill knows Steve, and Steve knows Bill's 2 cousins. Yeah, we got a 2 from Latoya Jackson, and 1 from Gloria, 2 from Lane. Yeah, and this, I think the answer to this question really is kind of maybe. Certainly the duration is sufficient, and the dose may be sufficient or not, and really it kind of depends. So this gets to the definition, what's an adequate treatment trial? Well, there are a couple different definitions of dose and a couple different definitions of duration that is adequate. But what I propose to you is that, from my interpretation of the literature, that we define an adequate treatment trial as the maximum tolerable dose for 8 weeks. So for example, if that person who was taking the sertraline 100 milligrams, if they didn't tolerate 150 milligrams, that 100 milligrams for 8 weeks may have been an adequate treatment trial for that person. Whereas if they've never tried 150 milligrams or 200 milligrams of sertraline, that dose may be inadequate, even though the duration was adequate. So maximum tolerable dose for 8 weeks is what I suggest as an adequate treatment trial. All right, next question. Patient with persistent depressive disorder hasn't found benefit from adequate past trials of escitalopram, duloxetine, mirtazapine, and bupropion. What would you suggest? Would you suggest 1, a fluoxetine trial, 2, a nortriptyline trial, 3, a venlafaxine trial, or 4, a vilazodone trial? What do you all think? We got a 2 from Rebecca Chavez. I think Latoya probably chatted something in. No vote would send to our med provider, which is Rebecca. Good answer, Latoya. And let's break this down a little bit here. So please, anybody, go ahead and unmute. What is escitalopram? What class of medicine is escitalopram?
SSRI.
Yeah, it's an SSRI, right. And then what about duloxetine?
SNRI.
An SNRI, right. Mirtazapine, what's its mechanism of action? This one's a little more abstruse. This is one of the serotonin 2 blocking medications, the 5-HT2 antagonists. And then bupropion, what's its kind of mechanism of action? What kind of medicine is bupropion? Anybody?
Is that a dopamine?
Yeah, it's what they call a norepinephrine dopamine reuptake inhibitor, or NDRI. It's basically a stimulant-like molecule, right? So we've got this person having adequate trials of an SSRI, an SNRI, a 5-HT2 antagonist, and a stimulant-like compound. And so looking down at these answers, what's fluoxetine's class? What class is that one?
SSRI.
Fluoxetine is an SSRI, right? What about nortriptyline?
Tricyclic.
Yeah, nortriptyline is a tricyclic antidepressant. What about venlafaxine? What's that one?
SNRI.
It's an SNRI. And then vilazodone is one of the newer SSRIs that also has some buspirone-like potential, right? And so of these options, which one actually presents a new mechanism for this person? Right, exactly, too. So this is the new mechanism here is the nortriptyline, a TCA. And this is a common situation in which you would want to switch to something that you might not typically use, like a TCA. And next question here. A patient with persistent depressive disorder not currently on medication has prior trials of fluoxetine 20 milligrams, sertraline 50 milligrams, duloxetine 60 milligrams, bupropion 450 milligrams. SSRIs and SNRI were intolerable due to sexual and GI adverse effects. Bupropion was partially helpful. What makes sense next logically? Does it make sense to trial escitalopram? 1. Does it make sense to retrial bupropion and augment? That's 2. Does it make sense to trial venlafaxine? That's 3. Or does it make sense to trial nortriptyline? That's 4. We got a 4 from Rebecca Jackson, and 4 2s from Gloria and Rebecca Chavez and Lane, 2 from Mariah Mahoney. Good. So what we're seeing here is that 2 SSRIs and 1 SNRI were intolerable to the patient because of sexual adverse effects. So escitalopram, what's that mechanism?
SSRI.
It's an SSRI. So chances are this is going to have sexual adverse effects for this patient. So that might be a non-starter for the patient. So even though these doses of these medicines may not have been adequate doses, the medicines were intolerable. So probably better not to revisit this SSRI. Whereas venlafaxine is an SNRI, probably just as likely to cause sexual adverse effects as the SSRIs. Nortriptyline is a possibility, and you could certainly justify using nortriptyline here. However, we have a clue here from the patient's treatment history that bupropion was partially helpful. And so, okay, well, let's take advantage of that and try to help it along with some augmentation. And that's the whole purpose of augmentation, is something that's been partially helpful, you help it along. So yeah, answer number 2. So here are some pearls for selecting treatment based on your treatment history. So if a treatment or a treatment class has been helpful in the past, retrial that treatment or that class of medicine with a higher dose, or retrial that treatment or that class of medicine with augmentation. So take advantage of that previous positive response and help to boost it. If a treatment or a medication class was intolerable in the past, acknowledge this fact and select an alternative treatment or an alternative class of medication. So if somebody says, I couldn't stand taking that sertraline, it caused me to have a lot of nausea and I had sexual side effects, it's probably best to say, okay, let's not do sertraline again. And then you move on to something else. And then if a treatment or a medication class was just frankly ineffective in the past, just acknowledge that and select an alternate treatment or an alternate class of medication. So, but what if I've exhausted the SSRIs and the SNRIs, right? So many of us in the primary care setting are pretty comfortable working with the SSRIs and SNRIs. They're very user-friendly. And we may be comfortable using bupropion, we may be comfortable using mirtazapine, but we may not be comfortable using other medicines from different classes or using the augmentation agents. Well, this is where I suggest venturing out into the unknown seas. And here's the map for you. And here's the normal land of SSRIs and SNRIs. And it's just called Calendradua. I don't know where that's from, but anyways. But over here, there's some dangerous territory, right? TCAs and MAOIs and augmentation agents, they seem kind of dangerous. Well, we can help you in selecting these treatments and in titrating them and in working with patients about the adverse effects that come from these treatments and in guiding patients through the process. So we can help with treatment with the 5-HT2 antagonists, mirtazapine, trazodone, or nifazodone, or some of the new SSRIs with the buspirone-like potentials like vilazodone or vortioxetine. We can also help with TCAs and monoamine oxidase inhibitors. We can guide you through the process of talking with patients about TCAs, talking with them about side effect expectation management, and helping to minimize the adverse effects of TCAs. We can help guide you through MAOIs and what dietary changes would be necessary for MAOIs. And then we're happy to help you with on and off-label augmentation strategies. I think next we're going to look at a list of effective augmentation agents. Oh, and then lastly, we're happy to help with guidance for referral to psychotherapy, transcranial magnetic stimulation or electroconvulsive therapy. So for those of you practicing in New Mexico, in Albuquerque at the University of New Mexico is the only operating electroconvulsive therapy service in the state. So anybody from New Mexico, if you want to refer somebody to electroconvulsive therapy, I'm happy to facilitate a referral. There are several transcranial magnetic stimulation machines in the state of New Mexico. There's one in Santa Fe. I think there are 3 in Albuquerque, including one at the University of New Mexico, and I'm happy to help facilitate that referral as well. And then we can help guide you for referral to psychotherapy if somebody has a co-occurring disorder for which psychotherapy is indicated. Okay, so here's a sort of a snapshot of one of these treatments that is can feel a little disconcerting to try, and also is very effective. And this is one of the first steps you would go to after you've exhausted the SSRIs, the SNRIs, bupropion, mirtazapine, and so on. So these are the TCAs. The TCAs are divided up into what they call the tertiary amines and the secondary amines. The tertiary amines are basically like an SNRI plus a 5-HT2 antagonist. So it's kind of like having Effexor or venlafaxine and mirtazapine together in one medication. The tertiary amines tend to be more anticholinergic, so that's like dry mouth and urinary retention and constipation and so on. And this is one of the major challenges of using TCAs, is the adverse effects. But there are ways that you can help to minimize those adverse effects and help people to tolerate them. The tertiary amine TCAs include imipramine, clomipramine, amitriptyline, and doxepin. These have been around since the 1950s, or at least imipramine in particular has been around since the 1950s. And so they're tried and true. We have a great deal of experience using these things, and they can be highly effective for patients who have not benefited from multiple other types of agents. The secondary amines basically are norepinephrine reuptake inhibitors and 5-HT2 antagonists. They're less anticholinergic, so they tend to be a little more easy to tolerate. And those, the main ones there include disipramine and nortriptyline. And these are oftentimes where we'll start off with a TCA trial because they tend to be more tolerable in terms of the anticholinergic effects. And the antidepressant doses of these medications are higher than the doses you might be accustomed to using for chronic pain conditions like migraine prophylaxis or neuropathic pain. Usually for those conditions, you're using like 25 to 50 milligrams of nortriptyline or 25 to 50 milligrams of amitriptyline. And so part of using these medicines to treat depression is building some comfort moving beyond that dose range and understanding that moving beyond that dose range has been done. We've had a great deal of experience doing that, and it can be done effectively and safely. Managing TCAs, you have to start off by understanding what the contraindicating conditions are, and then how to help patients tolerate the medication. So the contraindicating conditions for a tricyclic antidepressant include a recent myocardial infarction, a QTc interval greater than 450 milliseconds, heart block, or closed angle glaucoma. So this represents a very small slice of patients that are seen in primary care. Most patients who are seen in primary care, they may have had an MI, but it typically is not very recent. They probably don't have heart block or a prolonged QT interval unless they're taking something like methadone or another QT prolonging agent. Or they have familial QT syndrome or familial long QT syndrome. So outside of these conditions, the TCAs can be indicated. And expectation management is really important with TCAs. It's important to convey to your patients that the TCAs are highly effective medications. They can be very beneficial for people who have not had a good response to previous medications, and that the adverse effects, while they are common, they can be managed. So for example, if somebody is expecting dry mouth or somebody is experiencing dry mouth, you can use things like sugar-free gum or candy or moisturizing mouthwash or toothpaste, or you can also co-prescribe bethanechol. Is anybody familiar with bethanechol? Anybody used bethanechol for anything before? So bethanechol is a procholinergic medication that is used to treat urinary retention. And the only if the only thing that would contraindicate bethanechol would be if somebody has a history of reactive airway disease, because it's a procholinergic and it can increase respiratory secretions. But there have been studies that have looked at starting a TCA simultaneously with bethanechol, and it really helps improve the tolerability of that TCA. Not sure if I have any of the gum with me right here, but I typically carry around with me a little tub of xylitol gum that I chew it myself, but I also, when I'm starting a patient on a TCA, I'll actually give them a piece of xylitol gum to chew to see what it tastes like and show them what it looks like and tell them where they can buy it. And this can be really helpful for encouraging salivation in people who have dry mouth. It's important to use sugar-free gum and sugar-free candy to encourage salivation without increasing the risk of dental caries. If somebody has constipation from a TCA, treating that like you would any other constipation using hydration, fiber, a bowel regimen if you need to. Bethanechol can be helpful in that instance as well. If somebody has some urinary hesitancy, like for example, if you're treating somebody with BPH, benign prostatic hypertrophy, and in addition to the BPH, they start to get some urinary hesitancy, you can use bethanechol for that, or you can more assertively treat their BPH. And then if somebody has vision accommodation problems, reading glasses, it's usually when they're seeing up close. You can have them use reading glasses, or bethanechol can help with that as well. So, and usually you're using TCAs in people who have used a number of other options. And so what they're looking for in these instances is hope for their treatment of depression. So many people will be willing to face these adverse effects with their management rather than continuing to stay depressed. All right, next question. After 8 weeks on venlafaxine ER 300 milligrams, a patient's PHQ-9 score drops from 22 to 18. How would you characterize this change? Is this 1, a non-response to an adequate trial? Is it 2, a partial response to an adequate trial? Or 3, is it a non-response? Or 4, a partial response to an inadequate trial? So 1s, 2s, 1s. And we got the chat, probably got a 2 from Krishna. A chat probably from Latoya. Oh, Lucia. Yep, a 2 from Lucia. So this is defined, this drop is a 2-point drop, so it's less than 25% drop. So this is defined as a non-response. This is an adequate trial of medicine, robust dose of venlafaxine of 8 weeks. And so this is how we estimate the adequacy of previous trials as well. We assess how well the person responded to them. So assessing response after 8 weeks of maximum tolerable dose. The definitions of response include remission, which is no symptoms for 2 months, or a PHQ-9 less than 5. Response is defined as a greater than 50% reduction. Partial response is defined as a 25 to 50% reduction, and non-response is less than a 25% reduction. And you can use the PHQ-9 to track this. So say you've started somebody on a treatment and you've titrated it up to the maximum tolerable dose and you're waiting for a response to occur. Well, what do you do during that 8 weeks? You can do things like encouraging exercise, encouraging social contact, encouraging them to do activities that are meaningful to them, encouraging them to eat healthfully, and encouraging them to adhere to their treatment. And these are very important parts of antidepressant medication management, these soft skills of antidepressant medication management. All right, next question. After 8 weeks on sertraline 200 milligrams, a patient's PHQ-9 score drops from 22 to 14. The patient has tolerated sertraline well to date. Which of the below would be most likely to benefit the patient? First off, is this a partial response, a non-response, a full response? What do y'all think? Anybody can unmute and just... partial response, non-response, full response?
Partial. It's between 25 and 50%.
Yep. Yeah, I agree, Rebecca. So given that, what would you do? Would you, number one, switch to duloxetine? Number two, switch to mirtazapine? Number three, switch to nortriptyline? Or number four, refer for psychotherapy? We got a bunch of fours. Good. Yeah, good. So you've got a partial response. So the medicine is doing something. And so which of these options would augment the depression response? And referring for psychotherapy is a good antidepressant medication augmenting treatment. So going back to the step of titration, augmenting, and switching, if somebody has entered into remission as a result of a treatment, continue the current treatment. If somebody has had a response or a partial response, what you do with that is either you titrate the medication if it's tolerable to do so, or if the patient is able to do so, or you augment. If patient has had a non-response, either titrate or augment or switch to another medication. There are some studies that suggest that augmenting a non-response can precipitate a response. There are other studies suggesting that if you have a non-response, you may as well just not use that base treatment and switch to another treatment entirely. So here are some augmentation treatments for resistant depression in order of published efficacy. The higher on the list being the more efficacious in terms of the size of their effect. Electroconvulsive therapy is the most effective treatment for depression that we have in terms of the size of its impact. Now we reserve it for treatment-resistant depression because it's not a trivial treatment. It requires a lot of time and commitment from the patient. Next, in terms of efficacy, is transcranial magnetic stimulation. And then next is psychotherapy. So people with resistant depression can do quite well with some boosting CBT over the course of 12 to 18 weeks. And then going down are some of the augmentation medicines like quetiapine, which is Seroquel, aripiprazole, which is Abilify. T3 is liothyronine. Modafinil is also known as Provigil. It's a wakefulness promoting agent. Brexpiprazole is known as Rexulti. It's one of the newer antipsychotic medication augmentation agents. Lithium can be an effective augmenter with a blood level of between 0.4 and 0.6. And then pramipexole is also shown to be an effective augmenting agent with a dose between 0.5 and 4 milligrams.
Hi, Brent. It's Lucia.
Hi, Lucia.
Could you explain TMS a little more? Because I know so little about it.
Yeah, sure. So transcranial magnetic stimulation is a treatment that stimulates an area of the brain that essentially gets shut down when people are depressed. So it's this area up here, the left frontal lobe. And this is the area that's responsible for things like problem solving, for things like recognizing what a useful emotion is and what a non-useful emotion is for a given situation, and helping to sort of navigate through emotional responses to situations. So people with depression, they have a hard time even solving simple problems. They may, look at doing the dishes versus vacuuming their living room and not be able to decide between the two for the entire day. And then they feel horrible about the fact that they couldn't decide between the two because it's just too overwhelming. So that's a sort of phenomenon that might correlate to this dysfunction of this brain area. Similarly, people with depression, if they have an emotional reaction to an event, like say somebody says something that's a little off color, right? They might be more likely to take it personally, or to have irritability about it, or to feel sad about that reaction, or sad about what that person has said. And they don't know to sort of look at that emotional response and say, oh, this is a little bit out of sorts with regard to the situation. So that's also something that area of the brain does. So transcranial magnetic stimulation uses a magnetic field to directly stimulate that area of the brain. And by stimulating that area of the brain, basically altering the circuit that is dysfunctional in the state of depression. It's delivered once every weekday for 4 to 6 weeks, and it takes about 20 minutes, half an hour per treatment. So it's a big time commitment, but it's highly effective, and it's very, very well tolerated. More tolerated than ECT.
And
Question, Lucia?
how would you distinguish between giving ECT versus TMS?
Well, TMS does not result in a seizure. TMS is just stimulating a very specific area of the brain cortex. ECT has its therapeutic action, at least it's thought to have its therapeutic action, by inducing a seizure and by inducing the body's own mechanism of shutting down the seizure. So whenever you have a seizure, your body has, number one, it has a massive release of catecholamines like serotonin, norepinephrine, and dopamine. And then your body also has mechanisms that shut down that seizure. And so these could be things like the endocannabinoid system. These could be things like the GABA system. And something about the regular application of a seizure, this massive flooding of catecholamines and the body shutting the seizure down, tends to promote growth in the brain, tends to stimulate growth in areas that have been affected by depression. It's not a very well understood mechanism. There's a lot of science that has gone into this, and it's not a good one-liner to describe why ECT works.
I know.
We just know that it works.
Wondering how you would decide. I had a very resistant, depressed patient, and he did TMS for about 40 sessions, and he had no effect.
Right.
And I was just wondering how you would. It was Dr. Kane's patient, and how you would decide between ECT and TMS. And also, my other question is if TMS is covered by Medicaid or if it's usually paid out of pocket.
Yeah, great questions, Lucia. Last week we did a didactic about referring to behavioral health. Not last week, 2 weeks ago, we've had a didactic about referring to psychiatric consultation, including some parts about referring to TMS versus ECT. The decision-making process is essentially this. Number one, Medicaid does not pay for TMS, whereas it will pay for ECT. So that kind of directs you in that regard, unless your patient has a disposable income. And most Medicaid patients don't have disposable income. This is part of the reason why they're on Medicaid. If you need to have for somebody to get a very prompt response within the next several weeks, ECT has a much more prompt antidepressant response than TMS does. ECT is also evidence-based for treatment of psychotic depression, for treatment of melancholic depression, and for treatment of depression with catatonia. So if you have those specific kinds of depression subtypes, ECT is your treatment of choice. So if you have somebody that has severe depression that needs to respond very promptly, or if they've got psychotic depression, melancholic depression, or catatonic depression, ECT is the treatment of choice. If you've got somebody who's got a lot of cognitive deficits and you want to use the treatment that is going to be most preserving of cognition, TMS is probably your treatment of choice. Does that help answer your question, Lucia?
Yes, thank you.
You're welcome. Has anybody used these augmenting medications like quetiapine or aripiprazole or brexpiprazole, modafinil? Anybody have any practice using these things? This is good because it means that that there's a lot of opportunity for utilizing these things in your practices. And getting familiar with them can really expand your repertoire of depression treatment. All right, so then we go back to our depression treatment algorithm, and you would just apply the same algorithm for resistant depression that you did with non-resistant depression. So after you've defined what the patient has tried, what's been effective, what's been ineffective, what the patient's tolerated, what the patient hasn't tolerated. You use that information to select the class of medication that is indicated, whether that's a TCA or an SNRI. You titrate to the max tolerable dose times 8 weeks, and then you respond to each of these contingencies by doing what's indicated. If it was intolerable, you switch to a different class. If the person was in remission, you continue the medicine. If the person had a response, titrate or augment. Partial response, titrate or augment. No response, switch to a different class. So instead of, like I said before, instead of having a huge flow sheet with all these medication names and do this first and then that next and this first and that next, just use this kind of simple logical algorithm. So in summary, treatment-resistant depression occurs in about 1/3 of cases of depression. Antidepressant treatment history helps guide treatment selection in resistant depression. Some patients will have depression resistant to numerous SSRIs and SNRIs. Learning how to manage TCAs can help primary care teams expand their repertoire of antidepressant treatment. And then numerous evidence-based augmentation strategies exist, including psychotherapy, TMS, ECT, and various medications. And we're here to help you all with these cases of resistant depression. So a couple more introductions to run. We'll have a little brief section for questions. Looks like we got Lane. Lane, please go and introduce yourself.
Lane Bradfield, family nurse practitioner in Albuquerque.
Great, welcome Lane. And we've got, let's see, Krishna has joined us as well. Krishna, go ahead and introduce yourself.
Sorry, I was a little late. My name's Krishna Katari. I'm a family nurse practitioner at an FQHC in North Carolina.
Welcome. And then Luis Gonzalez, please go and introduce yourself.
Hi, everyone. This is Luis Gonzalez, pharmacist clinician with the University of New Mexico Hospital. Thank you.
Welcome, Luis. And then Brenda Hensey Nelson from Interior AIDS Association. I think you chatted in, and if I remember correctly, Brenda, you typically don't have audio connection. Yeah, okay, correct. Yeah, welcome, Brenda. Okay, so questions about the didactic? Any questions about the didactic?
Where do you find the form for the treatment history that you mentioned in the list?
Yeah, the Maudsley staging method, right?
And also the prior treatment history form where you can kind of assess what patients have been on previously?
Yeah, you know, there's not one that's sort of already built for that. I usually, in my own practice, I do it, from memory because I've been doing it such a long time, right? And other practices may find benefit from listing out the treatments and little check boxes about like dose, duration, tolerable, effective kind of thing. Now that's certainly something that we at ECHO could put together and sort of and disperse out. Would you all like something like that for your practices? Okay.
Definitely.
Sure. Yeah, we can put that together as a project. Yeah. Other questions?
Hello, this is Mariah.
I'm right.
I have 2 questions. One would be any comment on how to monitor for serotonin syndrome, which I think a lot of us in primary care have never seen, but we try to be aware of. My second brief question is if, similar to the PHQ-9, if the Edinburgh post-depression scale is also can demonstrate response to treatment.
Well, that is a great question, Mariah. Whether the Edinburgh, so the Edinburgh scale is the scale for peripartum depression. Does anybody know if that's sensitive to change? Yeah. And Lucia, are you at Northeast Heights, or are you also doing the perinatal treatment?
No, I'm at North Valley and at Trisco. So.
Gotcha. Okay. Gotcha. Yeah, let me look into that Edinburgh question, Mariah. It's a great question. And then your second question was, I got distracted by the Edinburgh.
Serotonin syndrome.
Oh, serotonin syndrome, right? So, who in the audience has seen a case of serotonin syndrome? Rebecca has seen a case of serotonin syndrome. And Rebecca, was it a single case of serotonin syndrome? Have you seen several? Just one, a single case, right? And Rebecca, how long have you been practicing? Just how many years? Just hold up your hands. Now you're unmuted, so you can.
Like 15.
15 years. So 15 years of psychiatric NP practice, right? And seen one case of serotonin syndrome. So this actually illustrates just how rare this condition is. So it usually comes on when people have like multiple serotonergic medications stacked on top of each other. So for example, if you have somebody who's taking an SSRI and they're also taking tramadol and they're also taking their triptan for their migraine prophylaxis, and then somebody starts them on linezolid, which is an antibiotic that has monoamine oxidase inhibitor properties. And by the way, they're taking a supplement of serotonin, like 5-HT supplement, right? That might be, serotonin syndrome might arise in that case. Whereas if you've got somebody who's like taking fluoxetine and you start trazodone, pretty unlikely. Somebody who's taking like venlafaxine and they take a triptan from time to time to abort their migraines, pretty unlikely. So it's a fairly rare condition. After the case presentation, Mariah, what I can do is I can bring up a little infographic about the serotonin syndrome, and we can go through the different signs of it. I can bring it up on my laptop, and I can share with the network. Would that be useful for you all? Okay, cool. Other questions?
I saw, and I came a little late, but I saw on the slide that it said that oftentimes you should consider bipolar disorder for treatment-resistant depression. Is the MDQ the only thing that you use to screen for that?
Well, the MDQ is probably the most commonly used one. The trouble with the MDQ is that it's got good specificity, but not very good sensitivity. And so I use the MDQ to facilitate a conversation with the patient about mania. And if they endorse the symptoms on the MDQ, I'll talk with them about like, okay, when did this happen? What was it like for you? And ask them to tell a story about it. And if that story sounds pretty convincing for mania, great. That helps to clinch the diagnosis. It's important to revisit the diagnosis of bipolar disorder and treatment-resistant depression because there are higher rates of sort of undiscovered bipolar disorder in people with treatment-resistant depression. It's not a guarantee. It's not a slam dunk. It's just something to be aware of. This might be why this depression has a resistance.
Do you then choose like a adjunct medication like Seroquel or Abilify if you are convinced in a conversation? Like if you have a patient that's on an SSRI with, poor response?
Krishna, I think I could pay you for your anticipation of our next didactic next week, which is treating psychotic depression, and then the following week is treating bipolar depression. So we'll actually have a didactic that's dedicated towards what to do if you think your patient has bipolar depression. So it's a great segue for our upcoming didactics. And if you want to have the sort of answer a little more promptly than that, we're happy to share the slides with you from that treating bipolar depression didactic.
No, that's fine.
On the resources page too.
They're also on the resources page as well.
Okay, thanks.
Yeah.
Sorry, I didn't want to cut the lead.
No, it's quite all right. It's perfect. It was great. Like I said, we could pay you to be our spokesperson for our next didactics. The brief answer is that you would probably steer away from the antidepressant medications, and you would start something with evidence for bipolar depression, such as Seroquel or Latuda or Zyprexa. Okay, well, let's transition over to our our case for today. Krishna submitted a case for today. Let me bring the case up, Krishna, and then when you have it up, you can take it away.